Have you got time for me to discuss a patient with you?
Sure.
I've got an elderly lady who's got bilateral leg pains, calf pains.
And what's this patient's primary complaint?
Mainly walking. She's limited to about 5 or 10 minutes. Comes on very quickly.
Does the patient have any back pain along with this leg pain?
It feels quite heavy and cramping into her legs.
Yeah, and does she get any back pain with that?
No, although she has had a little bit in the past.
So what's your primary hypothesis in this case?
Well, I'm thinking lumbar-spinal stenosis.
And what other conditions might present in this way as well?
The main alternative would be peripheral vascular stenosis. It could possibly be a stenosis of the thoracic or cervical spine.
Yeah, let's take a look at the skeleton here. Stenosis is usually caused by degenerative changes in multiple areas of the spine. So you can get some central canal stenosis, or you can get patients presenting with foraminal stenosis as well. So oftentimes there's some degenerative changes in the disc which cause narrowing of the foramen and can also cause compression anteriorly, but they usually get combined changes in the posterior elements, so some facet joint arthropathy and ligamentum flavum thickening. And these changes combined narrow the foramen and cause that neurogenic claudication, often leading to the leg pain and cramping. And the spinal stenosis, as you know, is position dependent. So any posture or position where the spine is in extension or lordosis naturally narrows the foramen and will bring on their symptoms. And if they go into a flexed posture, such as sitting, they'll often get complete relief because it opens up the foramen and then that nerve has lots of space. Let's go through an assessment.
Yeah, she had very flattened lordosis.
Yes, and that's a typical kind of posture that they adopt over time with lumbar spinal stenosis. It's a pain-relieving posture. They may also be flexed forward at the hips if their symptoms are quite severe. And what would you expect with range of motion?
The flexion actually was full and relieved discomfort, but the extension was limited and brought on her pain. Side flexion, again, was slightly worse to one side than the other, but it was worse on the side that she gets more symptoms in.
Yeah, so any kind of closing down patterns that narrow that foramen will bring on their symptoms. So extension will be more painful, and flexion is often full in these cases. It's often useful also to look at side bending to the right or left if the patient does have unilateral leg pain.
Yeah, and she was more restricted on the left, which is where the left side was worse.
And did you check her neurology?
Yeah, and I checked it in sitting and it was normal, but I suppose it would be, wouldn't it? Because it's in sustained postures that she'd get any sort of neurological findings.
Yes, so oftentimes these patients don't have any specific neurological deficits related to the spinal stenosis. You may pick up generalized sensory deficits in the lower limbs or even dampened reflexes in the elderly population, but it's nothing specifically related to the stenosis because oftentimes the neurological compression isn't sustained, as you mentioned. Thinking about the examination again, what's an important test to do to determine your differential diagnosis?
Yeah, I checked peripheral pulses and they were normal, so I assume that it's not a peripheral vascular compression.
And what else might you want
stenosis.
to test?
And I've also checked Babinski and Clonus, and they were negative, which suggests that it's not an upper motor neuron problem either.
Yeah, so it is important to check those upper motor neuron signs if you do suspect that the stenosis might be coming from higher up, such as in the thoracic or the cervical spine. So if you've done all of your testing and the subjective questioning also leads you to believe that this patient does have spinal stenosis, what's the best course of management?
Well, I was thinking that I'd give her a course of physiotherapy, some manual therapy, and some exercises, mobilising exercises, and some advice generally. And if that wasn't beneficial, I was wondering what could be done from an orthopaedic point of view?
There is an option for injections and even surgical decompression,
Right.
but they would have to have an MRI scan that confirms the spinal stenosis, and the patient would also have to be interested in having some kind of orthopaedic intervention.